My name is Rajagopal. I am a doctor. I am a palliative care doctor. I direct the WHO Collaborating Center for Training and Policy on Access to Pain Relief based in Trivandrum, but with a jurisdiction over Southeast Asian region countries. I also am chairman of the non-government organization by name Pallium India. The official World Health Organization's definition of palliative care is about a mile and a half long. I'll pick out the crux of it. Palliative care is treatment aimed at quality of life in life-threatening diseases for the patients and their families. Now, when we say life-threatening, that's the official term. Let us first understand what it means. It doesn't mean life-threatening only in terms of length. If I am paralyzed and confined to these four walls, my life is threatened in the real sense of the word life. It's not just existing. So, if quality of life is seriously impaired, treatment aimed at improving it is palliative care. There are a few footnotes officially given and the definition is not complete. How do you achieve that? You prevent and treat suffering. You prevent and treat suffering by identifying and early identification and early treatment of physical symptoms like pain, psychological, social and spiritual issues. If I have a disease, I am not just a container of disease, I am still a human being. With all these domains of life are important to me, the emotional, the social, my relationships, the spiritual issues, this is all important to me. So, you find out what my problems are, take away what you can and improve my quality of life. An additional footnote, this goes hand in hand with curative treatment, with disease specific treatment. All along, as your chemotherapy is going in, as radiation goes in, palliative care walks with you to improve your quality of life. In 2015, The Economist did a global study covering 80 countries in the world. They studied the quality of death, how people live with the disease and die. India ranked among the worst 15 countries to die in. It pointed out the lack of access to pain relief, the lack of access to palliative care, the inappropriate treatment offered by isolating people in intensive care units even when dying of incurable diseases. With such inappropriate treatment, we are as if now among the worst countries and to die in, and that's terrible. The same study, you can find it if you just Google for quality of death, The Economist. The same study pointed out Kerala as a beacon. It said by the work of non-government organizations and with a government policy, Kerala has included palliative care in healthcare, and that with the involvement of the community is a model for the rest of the country and the rest of the world. That's what the report said. So, India, not very good. One of the worst things that we do is that though we grow poppy legally, we make opium, we export it to the rest of the world so that they can have the miracle of pain relief with morphine. We are denying it to our own people. The law was a major block. It took us 19 years, but finally in 2014, the Indian Parliament changed the law. The law is more friendly now. But between making a law and implementing it on the ground, there is a huge gap. It's going to need a lot of work. 29 individual states have to implement it without diluting the spirit of the amendment. So we have a long way to go. It is absolutely essential that the government should have a policy to make life livable for people with diseases. What's happening now is cruel. Now, a policy in that cupboard or in a computer doesn't mean anything in our country till it has guidelines and a strategy for implementation. That's where the gap lies. Now, just having the written policy is meaningless unless there is concurrent education of professionals. In India, you won't find it easy to believe, but our medical students and our nursing students, even today, do not have pain management as part of their curriculum. The Medical Council in 2012 agreed before the Supreme Court of India to include it. It has not happened yet. So the medical student is learning to diagnose diseases and to cure it, but not what to do when it cannot be cured. So they very often keep on applying the curative treatment even in incurable situations. That's a sad fact. So government policy is necessary, as has happened in Kerala. Kerala became the first government in the developing world to create a palliative care policy. It created in 2008, and the government has a national program for palliative care created in 2012, but without adequate budget allocation. That's a long way to go. Today, now that the Parliament changed the law improving access to pain management, the greatest need is for inclusion of palliative care, humane, compassionate care including pain management, into undergraduate medical and nursing curricula. Fortunately, again, Kerala is showing the way. Just a couple of months back, the Kerala University of Health Sciences decided to include palliative care, integrate it into the existing curriculum. The medical concepts curriculum is there, decided to integrate it into medical education and nursing education. That is going to mean a lot. And maybe once we show how it is done, the other states will follow suit. I chair the organization called Pallium India. This followed the work of my colleagues in the first 10 years with me, where Kerala had some reasonable reach of palliative care, and we found through the rest of the country growth of palliative care was negligible. That's for the purpose of Pallium India, which was formed in 2003, and of our institute in Trivandrum, which was formed in 2006. What we try to do is to find committed, threefold action. One, find committed individuals and institutions, especially outside Kerala, and encourage and support them to start palliative care services. We have now spread over 15 states. We have made this happen in 18 institutions. It's only a beginning. Secondly, we keep advocating for policy and where necessary changes in the law. This we feel as perhaps the most important part of our work, and that advocacy includes advocating for changes in the curriculum and the education system. Now, we also concurrently work with influencing state government policies. That's also something that we attempt to do. Now, in Trivandrum, we directly give patient care. That is certainly something that we enjoy doing, but it's also demonstrating quality care. People come to us for training, and theory is not enough. They have to learn They have to by observe and learn how to give proper palliative care. But the big task is not just to keep on creating palliative care centers like this, but to integrate into routine hospital practice. Now, two institutions, one in Kolkata, that is Thakurpukur Cancer Center, and one in Assam, Kachar Cancer Center in Silchar. These are two institutions which are now pain-free hospitals. That is, every person is asked, do you have pain? And if they want, pain management is available to them. That is one tiny beginning. Similarly, in all hospitals, eventually palliative care integration is necessary. Change is always resisted, and in our country, change is very often slower than in the developed world. That's a reality. But 5 years from now, what I do see happening is that the 2014 amendment of the law improving access to pain management will be implemented, hopefully, at least in half the states effectively. I specifically lay emphasis on the effectively. I see at least a dozen medical institutions, including palliative care, in their teaching. And if you ask me, for 10 years, I see the national body, which is Medical Council of India today and maybe Medical Commission tomorrow, that body integrating it into the curriculum as a whole. I also see improved access in the majority of major hospitals to the essential medicine. In Government of India's list, oral morphine and injection morphine are classed as essential medicines, and today 99% of hospitals do not have the essential medicine, because even if they did, doctors are afraid of it, they haven't seen it, they haven't used it. So I see an improved access to this essential medicine in the hospitals as a whole, and not only just access to the medicines, the multimodal pain therapy, all the elements needed to treat pain and suffering, I expect happening in more institutions. But along with that, one major thing that I have not mentioned yet is the way the community involved in palliative care in Kerala. You go outside and talk to 10 people, have you heard of palliative care? They may not be able to define it, but the man on the street in Kerala understands palliative care. Everybody knows a volunteer who is contributing to it. People of Kerala have embraced it. They have accepted it as a fact that if a fellow human being is suffering, you, if you are reasonably healthy, have a duty to lend a hand. Palliative care is a community activity now. The community involvement in palliative care today, I am sure, will mean involvement of the community in healthcare as a whole. I see a transformation happening where today healthcare is something that is given by the hospital to those who come to it. Tomorrow, I hope to see a healthy system where treatment is a partnership between the healthcare system and the patient and the family on the other side, where autonomy is respected, where the individual's wishes, not only the disease, the human being is respected and treated.